I would like to now turn to more of what I call some terminology madness. We've discussed use of measure to mean metrics, and there seems to be no getting around this misuse. However, in this lecture, we've sort of slid by some other terms that can also be confusing and are very similar to each other. Most of this terminology madness is used in some form of evidence-based medicine practices. So let's start and end this discussion looking at evidence-based medicine. This is the conscientious, explicit, judicious, and reasonable use of modern best evidence, that is, a body of factual information, in making decisions about the care of individual patients. Evidence may be classified by the rigor with which it is derived, ranging from evidence obtained merely from experts to that obtained by the most rigorous analysis of several randomized controlled research studies. Evidence should be applied in all forms of measurement and in use of guidelines, protocols, and so forth. But while there is good agreement on evidence, there is less agreement on definitions for the terms which describe how this evidence is applied, though there is some common usage that helps suggest some differences. Quality measures, as we've said, has been defined by CMS as tools that help quantify healthcare processes, outcomes, patient perceptions, and organizational structure and/or systems that are associated with the ability to provide high-quality health care and/or that relate to one or more quality goals for health care. The goals, of course, being the triple aim: quality, cost, and experience of care. Clinical practice guidelines are systematically developed statements to assist providers, patients, and third parties conducting clinical reviews, audits, etc., in making decisions about appropriate health care, generally focused on a primary condition. The development of clinical practice guidelines or clinical guidelines has become more rigorous and use more transparent. In assessing what guidelines to apply, understanding the degree of rigor applied to the evidence supporting the guidelines is important. Now, some of the other practice protocols, pathways, etc., can also be distinguished in common usage, really. Practice protocols, for example, are typically considered a course of treatment, a suggested course of treatment, including a logical flow of interventions and detailed recommendations for a specific condition. There's actually usually a specific flow chart in this practice protocol. Practice protocols are more specific than and should be based on clinical practice guidelines. Practice protocols is a term often used by physicians, especially in use of episodic care, so eventually in bundled payment. Clinical pathways are similar to practice protocols, but more detailed and often focus more on overall patient management than a specific treatment regimen. As such, clinical pathways are often interdisciplinary and used by a care team of physicians, nurses, therapists, etc. Care plans provide detailed guidance for each stage of managing a specific patient. They are commonly developed at the start of a care event, such as a hospitalization. Increasingly, they are also used with patients to engage them in ongoing medical and health care. Care maps are very similar but tend to focus on coordinating care across the continuum for a given patient. I think care plans and care maps will become extremely important as we go forward with value-based care. Now, standards are statements identifying a desired outcome that has been achieved through consensus by experts, ideally based on some level of rigor. And typically, standards are mandated through either voluntary agreement, we'll all use this standard, or government mandate. Policies are statements relating to courses of action, generally established through a governance process at an institutional or governmental level. There is not necessarily that same level of consensus that is standards, but it could be. Best practices, finally, is a term starting to be used a lot in healthcare, especially in value-based care, primarily referring to how operational processes should be performed to achieve best outcomes. So really best practices is looking more at the operations side rather than the clinical side. Best practices generally exist in the absence of any of the above if we're using them for clinical care, but that rarely is really the thing to do. So now that we've reviewed these terms commonly associated with how to practice medical and health care in a manner that will produce good outcomes, let's return to the discussion of evidence-based medicine. And again, a lot of terminology madness here, maybe more madness in terms of skeptics in the medical field and their belief that every patient is unique and standardizing treatment cannot apply to all patients. Many physicians literally become mad over this level of standardization, angry. While the fact that we are all unique and our uniqueness definitely should be incorporated into our treatment, this is certainly true. But many physicians miss the point that evidence-based medicine is not a prescription to do something only in one specific way for all patients. In fact, an evidence-based medicine triad has been described by several notable individuals as early as the late 1980s to mid-1990s. It's been canonized in the work led by the Oxford Professor of Medicine, Dr. Sackett, in 1996 in the British Medical Journal. The point of the triad is to emphasize that evidence-based medicine relies upon individual clinical expertise, patient values and expectations, as well as best external evidence. It is, in fact, up to the physician to assess the patient, ask key questions, do a history, acquire evidence in the form of guidelines, protocols, etc., as well as diagnostic studies, physical examination, and so forth, and then apply all the evidence within the context of expertise and patient preference. And what we have often not done well next is to appraise the results. In fact, there has been so much concern about standardization, quote unquote, of care and discussions surrounding value-based care that misinterpretation of evidence-based medicine as one and only one way to do something has great potential to derail value-based care. For those of you facing this dilemma in your own organization, I would point you to an excellent commentary that appeared in the AMA Journal of Ethics in 2006, in which Dr. Mark Tonelli writes about a case of a patient, an attending physician, and a resident, where thoughtful and critical review of the assumptions underlying evidence-based care or evidence-based medicine and clinical expertise were called upon to resolve a patient care crisis. Clearly, evidence codified in quality measures, clinical practice guidelines, etc., is an important starting point in improving quality of care. And certainly evidence from our all payers claims database would suggest that there is a lot of variation. But we would not need physicians if they were not allowed to apply their professional judgment in treating patients. So with that thought, we'll conclude this unit with much to think about. References listed here may help focus discussions for you going forward in both convincing people to improve healthcare operations as well as to alleviate concerns.